Everyone has secrets. But then...
No.
Everything changed.
Listen, all you guys keep asking for
the worse.
is succinylcholine to use in the field.
He has been chosen.
For intubation. Let me just tell you, your intubation rates are not that good to begin with. And no.
Good versus evil.
Sucks isn't... I'm trying to sucks. You keep saying sucks. Okay, no, this sucks. This conversation sucks.
The world is no longer as you remember it.
Succinylcholine. All they ever ask for is succinylcholine. They want sucks. I'll give them sucks.
Everything is about to change.
Dry bones, them bones, them bones, them dry bones. Here's your succinylcholine in your face.
One man. One weapon. There is nowhere to hide. From the makers of Legally Blonde, critics are calling it absolutely terrible. A complete waste of $250 million.
He's here. I know he's here. I don't know where he's at.
When you thought you were alone.
No. He's gone crazy. You sucks is everywhere.
They will find you.
I don't know. I'm so scared.
911, what's your emergency?
And who's suspended? For bad. Them bones, them dry bones. Them bones, them bones, them dry bones, them... Oh, it's pretty dry in here. Dry bones. You says, yeah, you didn't see anything. Yeah, so, psychiatric emergencies. There's not a lot of literature or even education or training that goes into the handling of psychiatric emergencies in the pre-hospital setting. Most of the treatment modalities that are actually used are based upon emergency department treatment or psychiatric department treatment, outpatient psychiatric care. So the care of these patients is somewhat difficult and can be very stressful, not only to the patient but also to the provider of care out in the field. You know, if you look at psychiatric emergencies, they can be really any conduct that leads to a behavior that is intolerable to the patient's family, or to society as a whole. So an individual who's disruptive at a restaurant, who's suddenly screaming out bloody murder or singing dry bones somewhere, can be a psychiatric emergency that requires treatment. And you have been called to many calls such as that, where there's an individual acting strange, somebody sleeping in an area where they shouldn't be sleeping, or a person who's made some threat to their own life or to somebody else's life. The thing that we look at the standard of care once again for these patients is really not based upon a lot of evidence that in the pre-hospital setting. It's all based upon other treatments that have been done in other settings like the emergency department or in psychiatric units themselves. So that sometimes doesn't translate very well to the field, because you coming into a stressful situation and being stressed yourself can lead to patient mistrust, which can lead to difficult handling of these patients, and sometimes the patient not then getting the proper care that they require, either in the hospital or as an outpatient. When you're taking care of any of these patients, the thing you need to be aware of is that sometimes a presentation that seems to be primarily behavioral or psych may actually be an organic cause of the patient's problem. So it's very imperative that you as a pre-hospital provider go out into the field and start trying to rule out some of those other things that may be causing a behavioral change. And then that can go run the gamut of neurologic things such as stroke, an individual having a seizure or post-ictal phase, metabolic causes of things like hypoglycemia or thyroid disease, individuals presenting, even with acute MIs, can present sometimes with altered mental status, specifically in the elderly, hypoxemia, presenting as an individual with altered mental status, or even psychiatric types of behavior. Drug syndromes, of course, acute intoxication of some agents, or even withdrawal from some of those agents, can be some of the other culprits that actually can present similar to psychiatric illness and not really be psychiatric illness. So we have to be very cognizant that you have to rule out the organic things before you start going down the pathway of an individual being purely a behavioral problem. But once again, these behavioral problems can be very emergent. We can take, for example, the individual who's suicidal, and there's multiple presentations of suicidal ideations that can occur, from passive suicidal ideations, such as the person saying, I just don't want to be here on this planet anymore, to the active suicidal thought where the person tells you specifically, I'm going to take a gun and shoot myself in the head when my wife is at work. So that person who has active suicidal ideations is actually the more dangerous individual, to be quite honest, but both patients require care, of course, in the hospital, so that we can actually then care for those individuals and get their psychiatric care done as astutely and as quickly as possible. An interesting fact about psychiatric illness and suicide specifically, in 2005 there was some data that showed that suicide was the 11th leading cause of death in the United States. And in fact, there were more suicides that occurred, death through suicide, than through homicide. There were over 31,000 deaths from suicide in 2005 and approximately 16,000 deaths from homicide. So suicide is a very serious instance, and we need to take all those patients who make even the idle threat of suicide very seriously. And this kind of takes us into some case scenarios. When you think about your time in the field, when you've actually gone on some of these calls, some of the most difficult patients that you have to deal with are patients that have psychiatric illness like this. And one thing that you need to establish, of course, is a rapport with those individuals and some semblance of trust, so that they can trust you as a pre-hospital provider, and you can get them to that definitive care in the hospital. One other thing we find that's very concerning sometimes are these patients that have a third party call for them when they actually may have made a threat. It's very important that we err on the side of likely transporting these individuals to the hospital, even when there's a third party that makes a claim and the patient is adamantly refusing and telling you that they made no statement whatsoever that they'd want to harm themselves. We got to really take into account and think, why would some person make some false claim on an individual if they really have a concern for their well-being? It's best that we actually take a look at them in the hospital, and we can then make some determination of whether or not they have a credible threat or not at that point. And sometimes it's even difficult for us to make that idea of credibility for individuals when they make a threat to themselves or a threat to their life. There have been some cases where recently we've had individuals that have been brought to the hospital where a third party has called for them based upon text messages that have been sent back and forth from the parent to a child who was living out of state, and they became concerned and called police and EMS personnel, who did diligence and broke into the person's house and basically took them out because they had some inkling that this patient may do something to harm themselves. It turns out once we saw the patient here that she did not have any real suicidal ideation or thought, but she did have a psychiatric history in the past, and the family was concerned if some of the words that were sent by text were interpreted as the patient saying that she was going to be gone for a long time. In fact, the patient was actually going to be going on a date with somebody, a new beau that she was going on a date with. She said she was going to be gone for a while, and she was wishing her family good night, but they interpreted it as her wishing them goodbye forever. But the patient came in, understood that she needed to be evaluated, and was actually very thankful that people did care about her enough to call because they had some concerns regarding what she may have stated inadvertently in her texts. So we should look at all these patients that actually have psychiatric illness as true emergencies, and use all modes that we can to try and get them to come to the hospital where they can be evaluated and treated. In the field, you do have some modalities to help you with some of the patients that may be combative. Of course, using restraint and using it in a way that would be effective. In fact, using more chemical restraint than anything else. And we have to be cautious and make sure we monitor these patients very closely so that they don't cause harm to themselves or harm to you while you're transporting those patients to the hospital for definitive care. I just stared off into nothing for no reason. What was that all about? Am I hallucinating? There's some common factors that actually are taken into account that can lead to a higher success rate of suicide. Having schizophrenia, having a family history of suicide, having weapons in the home can lead to a higher success rate of suicide. According to Donald Trump, women commit suicide, or at least attempt suicide more often, but men are more successful at suicide. That's according to Trump 2016. And but it is true that women make more attempts at suicide, but men are more successful at committing suicide. So there are a lot of factors that have to be taken into account when you do have a patient that does have suicidal ideations, and when they are here in the hospital, we take into account many factors that may lead to them having a higher risk of actually completing suicide at some point. And some of those factors are their past psychiatric history, family history, history of weapons in the home, and then having male gender, that we are likely more to kill ourselves. So, yay us. Just gotta chillax, man. Just keep it cool, man. Just don't let the stressors get to you. I mean, I jump off of stages to take care of my stress, which is ridiculous. And I could also end up having a broken neck, so there you go. But truly, if there are stressors that are taking place, you have to have a network of individuals that you can talk to in confidence to actually take care of those stressors. And there's lots of resources that are available for you as firefighters and other medical professionals to actually seek care to help you with your psychiatric or any of the stressors that are in your life. But you got to stay healthy out there, because if you're healthy, and of course, then the world's going to be healthy because you're taking care of everybody out there. So we appreciate what you do. Be safe out there. Psychiatric emergencies are real and they are dangerous, and we should always err on the side of transporting these patients to the hospital whenever we get the chance. So be good. Till next time. Who knows? Maybe I'm going to jump out of a building on the next movie. You think? Screw that. I'm not jumping out of a building.
Suicidal?
Shut up.
Shut up. Hey, what are you doing in here?
Nothing. What are you doing in here?
Let's get back to work, huh?
You get back to work.